Good evening once again. At the, at the outset, I would like to thank Manthan and Mr. Ajay Gandhi for the kind invitation to share my thoughts at this amazing forum. I must say that I was very nervous when the invite came in, but then the journey to actually build this talk today has been very exciting for me. To introduce myself, I am Dr. Anthony Vipin. I'm a consultant ophthalmologist at the L.V. Prasad Eye Institute, situated in our very own beautiful city of Hyderabad. Today, I'm going to take you on a journey of exploration and discovery in healthcare technology that has defined our past, that has changed our present, and will also shape our future. We are living in very, very exciting times. The reason why I say this is that technology is transforming every aspect of the way we live. And perhaps no area is more important or more profound than the innovations we are seeing in healthcare. A right so basic, and we still have significant challenges to ensure that there is equitable, efficient delivery of care for those in need. Healthcare in India is at a crossroads. India has successfully eradicated many diseases, including smallpox, polio, and guinea worm disease. It has also emerged as a hub for generic drug manufacturing, and it boasts of a large public health infrastructure. Despite this progress, India continues to struggle with critical issues and gaps in its healthcare system. A strong bias during curative care reflects a culture that often neglects prevention and wellness. With an estimated economic loss of around $6 trillion due to non-communicable diseases by the year 2030, the maternal mortality rate at 178 against a Millennium Development Goal of 109, to around 3 million urban diabetic patients accessing adequate care from 38 million who need to be treated, are just some of the challenges that we face today. The population is aging. The elderly will account for an estimated 11% of India's citizenry in the year 2025. When it comes to vision impairment, India is home to the largest number of visually challenged individuals in the world at 15 million. Globally, 285 million people are visually impaired, 90% of them living in low-income settings, and 82% of them are greater than 50 years old. While all of these numbers may sound very grim, and they paint a very grim picture, 80% of visual impairment can actually be avoided if diagnosed and treated early. 1.4 million children could actually benefit from vision rehabilitation in the form of a spectacle. These are just some of the opportunities that have the potential to change lives. When we come to healthcare technology, it's a very broad field where innovation plays a crucial role in sustaining health. Areas like biotechnology, pharmaceuticals, information technology, and the development of medical devices and equipment, and more, have all made significant contributions to improving the health of people around the world. From small innovations like adhesive bandages and ankle braces, to larger, more complex technologies like MRI machines, artificial organs, and robotic prosthetic limbs, technology has undoubtedly made an amazing impact on medicine. As a result of the development of these brilliant innovations, we continue to find ways to improve our practice, from better diagnosis to better surgical procedures and also improved patient care. I would like to share a few game-changing innovations over the centuries that have revolutionized medicine. In 1714, Daniel Gabriel Fahrenheit invented the first Mercury thermometer, which is still used today, that is phasing out with the use of digital thermometers. William Conrad Roentgen won the first ever Nobel Prize in physics in 1901 for his discovery of electromagnetic radiation in a wavelength range known today as X-rays. Roentgen tested his invention by photographing his wife's hand, which clearly revealed her wedding ring and the bones in her fingers. The cardiac pacemaker, a small implantable device that regulates the human heartbeat, has saved millions of lives since it was invented in 1926 by Dr. Mark C. Lidwell, supported by physicist Edgar Booth. Today's pacemaker batteries can run for up to 20 years and even be recharged through the skin. So technology and innovation has always walked hand in hand with healthcare over the centuries. And central to all of these amazing discoveries was the patient and the need to serve them better. And the quest continues even today. Coming back closer to home, our major technological quest at LV Prasad Eye Institute began about 6 years ago, when the team, an in-house team, was tasked to digitize the entire network of LV Prasad. LV Prasad Eye Institute is a not-for-profit, public-spirited institution that is 154 centers strong, spread across 4 states of India. Over 130 centers cater to remote rural populations. The innovative eye health pyramid caters to populations at all geographic levels, enabling our patients to move across the vertical to access relevant care. The Village Vision Complex, which actually consists of 10 village vision centers, they connect to a secondary center, which in turn connects to a tertiary center in the city. And it has proved to be an effective model of referral of patients for higher care over the years. Over the past 29 years, LVPEI has served over 20 million patients, over 50% of them free of cost. Our published research has also helped design better medical and surgical care that is being adopted on a global level. And the opportunity to gain insights from the wealth of clinical knowledge is immense in our country today. And the ability to understand impact and implications of treatment that is being delivered is becoming increasingly important and relevant today. We embarked on a challenging journey to connect the entire LVPI pyramid in a seamless manner, to be able to see patient data at the click of a button, irrespective of where they've got into the pyramid. The vision is called Doorstep to Boardroom. This means that can we track a given patient right from screening at the doorstep, identify causes of avoidable blindness, refer them to an appropriate center of care for medical or surgical treatment. And in this process, we should be also able to track the care delivered including the final treatment outcomes. This today is a reality at LVPEI. Rolling out the in-house built iSmart electronic medical record system has been an amazing adventure as we moved across different geographies, right from the village to the town to the cities, across different languages, and as we interacted with different users. The interface where the user interacts with the technology solution is a unique experience, and it is our constant effort to make it better and seamless for them. iSmart EMR over the years has helped facilitate over 1.5 million patient consultations across the network today, and has created a wealth of information to mine from to design better care for our patients. After the journey started to evolve, there was something that was lacking. The circle was not yet complete. Rolling out a massive solution was just not enough. Just having all this data in our hand was just not enough. A chance conversation in the clinic with some of our friends from Microsoft opened up a brand new dimension to this effort. The world is moving to the cloud. The ability to analyze data and gain insights is becoming increasingly accessible and also affordable to everyone who wants it. Every sector, including finance, industry, and retail, are harnessing this power to redefine their services today. It was a bold and a landmark move for the organization to move iSmart's data to the cloud. And in this process, we ended up being the first healthcare data set on Microsoft Azure in India. It was a start. It was a very exciting start. A start of a dream to redefine how healthcare could be delivered, but in the process, understand, more importantly, how healthcare should be delivered. Today, LVPEI is transforming into a digital LVPEI that is connected. The ability for a clinician or a surgeon to have information of disease burden, to look at the wide variety of treatments that are being delivered, and also visual outcomes of our patients, has opened up new frontiers for us today. The opportunity to revisit the geographic distribution of eye diseases in India and the impact of the coverage of our services in real time has added a fresh perspective to our approach in the way we deliver eye care. And the potential to utilize the cloud is quite overwhelming. We are on the road less taken, for sure. And we truly believe that it is going to make all the difference for our nation in the days to come. Another exciting possibility that actually stemmed from this collaboration was the use of machine learning in our daily practice. Machine learning is a type of artificial intelligence that provides computers with the ability to learn without being explicitly programmed. Machine learning focuses on the development of computer programs that can teach themselves to grow and also change when exposed to new data. This enables us to design dataset models linked to clinical care to enable better decision making for our patients. I will share a couple of examples with you today. The first one came from our inability to answer the parents who would inquire about the progression of refractive error in their child. I would say we actually don't know the actual curve, but it may or may not progress. A regular checkup is required to address any change. This question kept nagging me. Why can't I answer my patients? Why can't I tell the parents of the children that I treat that, hey, this is what it could lead to, or this is what I can help you modify for better care? And with the help of data scientists at Microsoft, we've built a machine learning model today that can actually predict the progression of power in a child's eye for the next couple of years. The model today is currently being trained with more data to enable clinicians like us to be better informed. And today, when someone asks me, I just tell them, give me a couple of months and I'll be able to tell you how it's going to work out. In continuation to the same model, we also developed a predictive model around refractive surgery, which is a term used to describe surgical procedures that correct common vision problems like nearsightedness and farsightedness to reduce the dependence on prescription eyeglasses or contact lenses. The commonest procedure that you're all aware of is called LASIK, a procedure that is done to get rid of someone's spectacles. A complication that can occur in this particular surgery is that the glass power can return back even after the surgery is performed. We call this as regression. And that was an interesting problem to solve. And here we applied another machine learning model where we are now able to predict the expected visual outcome of the patient on day 0, on day 7, and on day 30 to identify individuals at risk and also correct this residual number during the course of the surgery to at least help the patient reach emmetropia and also avoid the complication of regression. What does this teach us? This really puts us into a zone of exploration where we can really look at understanding what we are doing and how it's actually affecting what we are advising. And also, more importantly, as time goes by, the data set gets better and better. To quote Albert Einstein here, he said, we can't solve problems by using the same kind of thinking we used when we created them. A welcoming trend that has developed over the past 5 years or so in healthcare is the concept of collaboration and co-creation. Anti-disciplinary conversations have led to forging of new bonds as individuals from different professions work shoulder to shoulder to innovate for the patients. Our journey in this exciting space began in the year 2013, when a chance conversation with Professor Ramesh Raskar from the Camera Culture Group at the MIT Media Lab, Boston, and Dr. Virender Sangwan from LV Prasad Eye Institute led to Engineering the Eye Hackathon that focused exclusively on the eye. The experiment was very simple. We said, can't we invite 100 individuals from across the country, 100 bright students who wish to join us? And we wanted them to come and work with us for an entire week on ideas to develop for the clinic. Designers, coders, mechanical engineers, industrial designers, they all worked closely with ophthalmologists and optometrists to actually develop 24 prototypes in 7 days. For me, on a personal note, I clearly remember on the end, on the valedictory, the graduation ceremony day, they showed us ophthalmology in a completely new, different perspective. And that was a great, great eye-opener for us. This laid the foundation of a dedicated lab for innovation at the Institute the same year with the backing of our chairman, Dr. G.N. Rao, and which was inaugurated by Dr. APJ Abdul Kalam. Today, Srujana Center for Innovation and the LVPEI Mitra program attracts amazing young talent from across India to work on projects to help deliver better eye care for our patients. I have 3 examples to share with you this evening in this particular sector. The eye is like a camera, and the film that captures the image is called the retina, which is affected by systemic conditions like diabetes mellitus. Early detection and close follow-up helps us to actually identify progression and also treat complications to preserve vision for our patients. We are developing a handheld fundus camera called OWL, also known as the Open Indirect Ophthalmoscope, to actually take pictures of the retina to detect diabetic retinopathy in our patients and actually refer them to the next level of care. The second example is that of the pediatric perimeter. Visual field that is tested in adults is difficult in infants because of obvious reasons, because they cannot respond back to you. So one of my colleagues, she had this idea. Can we have a dome-shaped device that helps identify visual field in babies by using a gaze tracking camera that assesses the direction of the gaze based on the stimulus that is presented to the baby? This today does not exist anywhere in the world. And it was exciting to actually see a local pediatric hospital who asked us for this device for preliminary examination of a baby before and after neurosurgery to actually assess the visual field of that infant. Open source solutions are changing the world today. We've already are moving from an amazing foundation that was laid when people decided to actually share their work on open source so that anyone, anywhere in the world can actually benefit and also add to that. Even for us at the Innovation Center, open source solutions form a very integral component of what we do. I'll give you one example. A designer from the National Institute of Design in Gandhinagar, when she came to our hackathon for the very first year, her quest was to make Braille playful to learn. And we all know that less than 10% of visually challenged individuals actually know Braille. And Braille is a very, very powerful tool for them to integrate back into the society and also to earn livelihood. Studies have shown that. And over 2 days, she came up with a 3D printable toy puzzle that actually has the letters of Braille embossed on it, and it is called as FITTLE, which means fit the puzzle. The visually challenged child fits the blocks together, learns the word in Braille, and also understands the form of the shapes of the objects. For example, a fish, F-I-S-H, on 4 blocks pieced together in the form of one. We didn't stop there. We also added an app to the component of sound, which is a very integral part of how visually challenged children learn. And for the child to actually experience what it is for a fish to gurgle underwater, what it is for a bat to hit a sixer in a stadium, what it is for a car to start the ignition. We made this open source on the internet. And the puzzles were downloaded on every continent except Antarctica, in 6 months. Further work is ongoing to develop the next set of 26 puzzles based on the alphabet and also beyond in experiential learning. What have we learned from this journey so far? When you co-create with different perspectives, we believe magic happens at that intersection. The ability to expand the horizons of a designer or an engineer to facilitate impact through their work directly to our patients has been the most gratifying experience in this entire effort. And the concept of social impact is so strongly rooted in them today for the underserved in our nation that they keep coming back to us year on end, asking us, Doc, what else can we do for our patients? They're all placed in amazing universities across the world, but it's heartening to see them connect with the clinicians to actually do something for our patients. Every amazing idea that is stored up in every doctor's brain today has the potential to become a reality. Times have changed. The way data has transformed the planet is just phenomenal. And the innovation ecosystem that is collaborative in nature holds immense potential as we explore together. We need to ignite this spark early on. The onus, I believe, lies on us clinicians to help amplify our impact with the use of technology. We need to raise a generation of clinicians that is sensitized to this potential and can utilize the amazing opportunities that lie ahead of them in the days to come. What does the future of healthcare look like to us today? There's so much happening around the world. Here is a sneak peek of it. There was so much to share, but then I thought I will introduce 3 concepts or 3 ideas to you to ponder on. There are many more in the making that range from nanobot drug delivery to robotic prosthetic limbs and also to gene-tailored drug therapy that is planning to actually design drugs that work for individuals based on their genetic makeup. The first one that holds great promise that is already entering the healthcare sector today is augmented reality. Augmented reality is a live, direct, or indirect view of a physical, real-world environment whose elements are augmented or supplemented by computer-generated sensory input. It sure is making inroads into healthcare today. I'll give you some scenarios. Imagine surgeons able to visualize the anatomical part even before the knife is put, to be able to analyze it from all angles of which is the best possible approach to actually treat our patients. Augmented reality also allows you to invite patients to scan packaging or printed materials to discover drug benefits and mode of action, and also what the side effects could be. The way medical education that is being imparted today is also changing with devices such as the HoloLens, a classic example being human anatomy. Imagine learning human anatomy in augmented reality. And to give you a more recent example of Pokemon Go, an app that is based on augmented reality that took the world by storm, quickly metamorphosed into an app which was more towards fitness. It was all about people walking and finding. The second idea I wanted to share is imagine the ability to print your own organs. The time frame for developing various types of 3D bioprinted tissues can be ranked from simple to complex. I'll break it down for you. Every particular organ is made up of tissue, and all tissues are made up of cells. And over the years, one of the greatest understanding for humanity has been specifically understanding how we differentiate our cells into different organs. And of late, over the past 3 to 4 years, one of the significant discoveries that has actually been made is reverse engineering of actual cells that have differentiated back to the original stem cell that started it all. And today, it is possible to actually print your organs from your own cells. 2D tissues like skin, hollow tubes such as blood vessels, and also hollow non-tubular organs such as the urinary bladder, and also solid organs such as the kidney have all been tried and have been printed. Researchers from the Wake Forest Institute of Regeneration have experimented growing over 19 organs now. 19. 3D bioprinting is going to help fill the huge void of organs required for donation someday in the future. The third exciting possibility, I believe, is collective learning. The world is connected now more than ever before. And the potential for all of us to learn from clinical data from around the planet is immense. Today, analytics and insights gathered from data in the past will actually drive the future. Initiatives centered around AI and machine learning are actually heralding a new era of understanding and reason in healthcare. They're also challenging some of the treatments that we thought work. It has been an amazing journey at the intersection of these verticals of technology, innovation, and healthcare for me. Over the years, I've come to define myself as an ophthalmologist by passion, an innovator by choice, and a maker by evolution. Technology, for me, has always been a philosophy. It is not just a means to design solutions for healthcare. The deeper dynamics underlying all of this includes the power of accountability in the delivery of care. This automatically translates into responsibility on the part of the clinician, eventually leading to trust between the patient and their care provider. Every individual walking out from LVPEI gets a medical report across the geographies, which clearly documents the entire conversation. This is a powerful tool to empower a patient to understand their ailment better and also encourage a positive health-seeking behavior. One incident that deeply touched me was when I was traveling to roll out our app in the rural villages in the village of Pedakotapalli. Whenever I go to the village, I let them know that a doctor is at hand so I can actually meet some of the villagers and at least address some of their doubts or refer them to our centers. And there was this one individual who said, "Doctor, I have something to show you. Can you wait?" I said, "Okay, I'm here for half a day. Please let me know." And he said that my wife was suffering from something. I just wanted you to actually see and let me know what that is. And he goes back to his home. It's a rural hamlet. And he brings out a printed record of a paper. And I take a look at that paper, and I find that it's a medical report that we printed 5 years ago from one of our secondary centers in Tudukurthi. And here is this individual who kept it so close to him because he values what we've shared with him. And more importantly, when I saw what she had, and I was able to even explain it to him even better, and he was quite reassured with the conversation. We need to revive transparency in the delivery of healthcare today. And technology is a great enabler for achieving the same. When my patients ask me in the clinic, "Doctor, why are you advising me exactly the opposite of what was told to me in my previous consultations elsewhere?" And I just smile and I tell them, medicine can be practiced in only two ways. The art of medicine can be practiced in only two ways. One is what the patient needs, and the other is what the doctor wants. Every advice and every treatment is based on just these two principles of what is guiding you. Moving forward, I believe technology will ensure and assist us to help deliver the best, not just better care for our patients at their doorstep. Technology today is enabling the preservation of life and the restoration of health on the planet. And it is an amazing experience to be at the intersection of both. Thank you. My argument is only very simple. When technology has penetrated every other aspect of your life, today we are all, it's the smart generation. Smart is a very, it might not be the smart generation, but it's smart devices. I think the need exists that we need to open this up to where we learn medicine. And I think it is not divergent. I think it is something that can go hand in hand. And as I mentioned, that doctors, we have ideas. We want to do better. But I think the environment today, the ecosystem today is even more vibrant for them to be supported and for that idea to actually, become a reality for the benefit. Yes.
Good evening, Doctor. I am Nagaraju, a member of Alliance Club. I was perhaps the first in the entire country to organize an IOL surgical camp outside a base hospital. That was more than 20 years ago. I have two questions. One, after listening to you about this very illuminative talk on technology, I wonder why this divide between, on one side, we've been making such massive strides in terms of technology. On the other side, we still hear of people contracting infections at surgical camps or surgeries inside hospitals, people losing sight, people being operated upon the wrong eye, and this kind of things. So how do you explain this divide? My second question is, you talked about 3D printing of tissue and all that. How close are we to 3D printing corneas?
I will answer both your questions. Thank you for your questions, sir. So the first question that you mentioned is that why is there this great divide, right? Well, the great divide, the blame is on both the parties, right? I mean, if I would just consider as healthcare and technologists, one thing is that the common thing that we listen among doctors is like, I don't have the time. I'm busy seeing my patients. But frankly, have we ever looked at, am I really delivering impact, right? So I believe that healthcare professionals should take the lead to a certain extent, right? And there are many groups or people working in different disciplines who are willing to actually associate for that opportunity to build something. And that is where amazing discoveries have happened over the centuries. So how is it more relevant right now? Access to industry, access to the facilities for you to actually take an idea to a prototype and a prototype to actual clinical testing has decreased significantly. Today, you can have an idea, you can 3D print it, you can get your institutional review board approval for clinical studies, you can actually get clinical data, go back to the lab, refine your device, and then move forward. So the simple example of what you've taken of surgeries, of wrong eye surgeries, right? I have a different take on that. A tool in a fool's hand is still a fool, right? So the user component always exists, right? Over the years, what we've seen is that it is a change of an individual or of a perspective before they actually come together to do some amazing things. So that's my take on the first part. The second part about 3D printing corneas. Yes, I was part of an initial group that was wanting to 3D print decellularized corneas for the general public. So the cornea is the black part of the eye, and also there are cells on the tissue. So you will have to actually remove all the cells before you can overlay the patient's cell on it, and then you are able to transplant it, which is a corneal transplant. Today, there are close to 800 to 900 people waiting for a single transplant in the state. And that's how much is the divide and the gap. But essentially, what we've evolved into today at LV Prasad is that there is a synthetic engineered cornea from Collagen. This is a group from Sweden that we are working together, Professor May Griffith and my mentor, Dr. Sangwan. It looks like a contact lens, the thickness being 500 microns. And you're able to actually produce it in bulk numbers. And we are hoping that someday this will be our answer to the lack of corneal tissues that we face today. And also, just to add a note, LV happens to be the largest corneal transplant center anywhere in the world, and we recently completed 20,000 corneal transplants. So, just to answer your question, another project that started 2.5 years ago with my same mentor, and we're working with a group in Pittsburgh, is to actually transplant an entire human eyeball. Today you transplant the cornea, but plastic surgeons believe that yes, with microsurgery, you're able to have anatomical success, and then we can understand functional success, right? And today, some of the questions we are answering in India is to understand how long is your eyeball viable when you actually harvest it. So to answer your question, yes, sir, we are on that path to actually ensure that there is no lack of corneas moving forward in the future. And some of the clinical trials have shown some fantastic results over the past couple of years. I hope I've answered your questions. Thank you.
Doctor, you have been talking of technology as largely relating to information technology. Mm-hmm. But another technology which will greatly impact medical science is biotechnology. In fact, actually, I think LVP has tied up with CCMB in this, especially in the area of stem cell research. Would you like to share some of the...
As I mentioned, as I alluded to the talk in between about stem cells and how we are understanding how tissues can regenerate. So LV also happens to have the largest stem cell transplant series anywhere in the world. I'll explain it to you. So whenever the eye has an injury with a chemical, which could be tuna or an acid or an alkali, what happens is that the white part of the eye grows over the black part of the eye. That is because there are cells at the junction between the cornea and the sclera that prevent the cells from the white part of the eye to actually grow over the black part of the eye. When they are damaged, the cells actually have no barrier. So way back, I think in 2000, when Dr. Sangwan and Dr. Geeta Vemuganti, the pathologist, were discussing about how stem cells of the cornea were grown on a sheet of amniotic membrane. So they said, why don't we try and see this in our patients to actually see if the cornea might work well. The reason why you need to replenish the cells is because if you replace the black part of the eye without replenishing the cells that cover the black part of the eye, which is the epithelial cells, it will fail. There'll be recurrent breakdowns and the graft will fail. So you need to actually increase the stem cells on site, after which you do the transplant. They went ahead and they created the cultivated limbal epithelial stem cell transplantation that allows you to take a piece of tissue from the normal eye, grow it in the lab for 2 weeks. And then after 2 weeks, you take that amniotic membrane tissue with the cells of the patient and you put it into the damaged eye. So that was what was done for over 7 to 8 years. But there was a brain wave. The brain wave was a tea bag approach. What is a tea bag approach? You have the components in the tea bag and you mix them and you make your tea. So what we then evolved into was the elimination of the lab itself. What better lab can you have than the eye itself? So instead of taking tissue and going to the lab and coming back after 2 weeks, today we directly transplant the bits of tissue onto the damaged eye, and the results have been even better than the cultivated limbal epithelial transplant. And that is called as a simple limbal epithelial transplant, because it's a simple technique. And with this, just as Sir was alluding, it is bench to bedside. It is bench to the theater, to the patient. How translational research is really, really changing the way, including the development of stem cells for retinitis pigmentosa or to understand how glaucoma develops. There is a strong component of research that goes into our work as well to understand why we are doing the things we're doing. So, thank you.
Doctor, all this talk about technology in healthcare and so on is fine. It's nice to hear. But even as we speak today, 70 years after independence, people are still selling their property, their Mangal Sutras and so on, for getting healthcare, either diagnosis or treatment and surgery and so on. So what are we talking about, doctor? I think we should be ashamed.
Well, yes and no. I mean, I would say it is true that a disease can destroy families. It is sad that when something afflicts an individual and they're not able to pay for it, they literally end up giving up everything just to be treated. It's a sad truth. In terms of access and the delivery of services, no matter what kind of infrastructure we place in place, one of the limiting factor always remains is the skill set and also the availability of trained professionals to be able to deliver care. That is another roadblock that we currently definitely face in the country today, which the government actually encourages young doctors to actually go rotate. But on the other end, the reason why I said no is that if I would give you examples of fantastic institutions that still treat people free of cost and have some amazing healthcare individuals treat them. If you look at probably cancer institutions, if you look at eye care institutions like LVP, if I may quote here, no patient is denied care irrespective of whether they can pay or not. The way this model is developed is that there are 4 categories of patient. The non-paying patients are someone who do not pay a single rupee irrespective of the complexity of surgery or the treatment that is required. The general paying patient, for example, pays a rupee. A supporter patient pays 2 rupees. The extra rupee goes for the non-paying who cannot pay. And a site saver pays 3 rupees for the extra 2 rupees. And it's all by voluntary effort and they're encouraged. The reason why I say this is that we in the clinic have the authority and the power to tell someone, don't worry, you'll be treated. For me, on a personal note, I think that is very powerful. At least I'm grateful that I am in a situation or an institution where I can tell somebody, don't worry about your payment, I will treat you. And the terminology I use for this is, I treat a beggar and a billionaire in the same chair with the same respect, the same conversation, and the same method of doing. And I consider myself lucky. I mean, I thank God for that. But I think the journey is long drawn. I think it's got multiple, factors to make it happen. But I think hope is all we have as we move forward, to at least touch people who need it. At least I believe those good souls are still there trying to do the best for the patients.
Thank you. I have two questions. The first question is that all what you spoke, the research which is being done, the development, and the entire process, tomorrow you will end up producing another human being without two persons meeting together. It is possible. The fact is, we live in a particular condition today. When we don't afford, the only solution is to cure yourself. If the body can cure myself for various ailments until we abuse it, but it will still cure without the help of doctors. And I am practicing that self-cure without medication for those ailments. Many of you say that there is no solution for that. That apart, my question arising out of this is there any development work being done to reverse the process of damage? The best process available in the whole world should be if I can reverse back. If the cell potential is 70 to 90 and that drops down to 30, the actual working of the cell is ended. By the time it becomes zero, it is become dead. If you can reverse from say 30 millivolts to, minus millivolts to 70 millivolts, why can't the new process of development work is taken up so that equipment can be such a low cost a patient can use before he finds the huge damage? Any work done on that? Number one. The answer to his question seems to be going around. His question is the same which I am asking. Anything we talked about, to what level of the people, financially or otherwise, it will reach? Is it only for the rich people? Then it is injustice to the humanity. If it is going to reach to them by reversing the process, and the cost is coming down, if the work is done on that, then I would say that the research work is based for the humanity. It has come for the rich people. Thank you.
Thank you, sir. I'm going to answer both your questions. The first one that you mentioned, I'm going to quote my mom here. She always used to say, she says, when the patient sees you, half their disease should go. That's how you should be, right? The first smile, the first thing. I'll answer your question. I, as a clinician and a surgeon, I know my limitations. I know my limitations in terms of knowledge that I have learned. I know my limitations in the treatment that is available. I know my limitations also that are factored by patients' economic expense, patients' situations, and many things that I even think before I utter a single word to the patient, right? But I don't undermine the power of willpower of how the body heals. There is very little of how much we actually understand of how people heal, of how you actually see people recover, or you see how people deteriorate. So I personally believe that we should be mindful of that. You know, the self-curing pattern, there's so much that we still don't understand about the body. And I hope moving forward, all these research and everything will help us guide back to our roots. I like the point that you said. It is not about us abusing it and then going back and saying, how do I now start to rectify it? You know, a lot of it right now that people are talking about is prevention, is wellness, is fitness. There's a lot of other things that is now becoming more ingrained into people's thought processes. So I think moving forward, a combination of us understanding of the beautiful natural process of how our body heals, coupled with less abuse of our bodies over the years, probably a point which may reach, I don't know in what time. The second thing that you mentioned is about, the rich, and it's not there. It should reach to actual people where it benefits. I'll quote my medical professors on this. I'll never forget what one of our professors said to me just before we graduated out. He said that you are what you are today, and the skill that you've learned or the knowledge that you've learned is what you are today, because some Malaya or some Bujama has allowed you to treat them. And he said, never forget them. Right? Never forget what you've trained for. Never forget for what you've trained for. And also what all I mentioned, again, as I've mentioned, it's a philosophy for me. It's not just going ahead and building solutions. For me, I believe innovation or technology, if it hasn't reached the person, the way I quoted, the farmer with the buffalo, the way you're able to touch them, it's a waste. And I think we need to be at it. It is a long journey, and we might not be able to change the entire world, but at least if you're able to make that impact in a region where it touches people's lives, I think that is...
Yeah, firstly, let me congratulate you, Doctor, and LV Prasad Institute to have treated 2 crore patients and to have made such a difference in their lives. It's an amazing journey. We are all proud of all of you guys, being citizens of Hyderabad. So that's just a small statement. My question, Doctor, is how do we replicate what you are doing? Creating a center of excellence with MIT, cross-pollinating ideas from across disciplines and translating them into actionable items, right, which make a difference to the end patient. How do you do that in many more fields of healthcare? How is the government spending, which is going to increase on healthcare from a per capita of $50 per year versus China's $500 and US at $15,000, as that spend goes up, how do institutes like LV Prasad, which are so eminent and carry so much of respect, how do you interact with the right government institutions to replicate what you are doing, Doctor? What are your thoughts on that? That's my question.
Yeah. Thank you for the question. Well, I think scale is always a challenge, because I believe scale is not just about the model, it's also about the people who are driving that scale. One good thing that I think that is being done is this exploration of the possibilities and the way we are able to design all these solutions. And if you're looking at a larger engagement, one of the strong things that we've been doing in the ecosystem along with T-Hub as well is to actually reach out to prominent institutions in the city. We work very closely with the Fernandez Hospital. We work very closely with Apollo to try to look at ideas where we can work together. Having said that, I truly believe that the journey is long, because at the end of the day, as Ajay said here, is that we need to go back to the roots. Once you go back to the root, and once a clinician knows that this is the potential, maybe they will be the agents of change that we've been waiting for. Because all the while, when we see groups wanting to do something for a particular vertical, the validation, the domain expertise is what everyone complains about. And I think that is where we need to strike hard, where we need to go and say, hey, this is what is possible. Do you want to go drive that? And I hope that will be the answer moving forward, rather than the number of buildings, infrastructures that we all build. But I think that's where it should come from. Thank you.
Yeah, I have a question.
Yes.
I read somewhere that a good physician is a 50% X-ray machine. In all this development of technology, are we missing the good physician and the skills he brings in. And we are converting him into a non-medical data analytic person.
Thank you.
What Sanjay asked is an important question. And the question is the replicability of an ecosystem that has been built, especially around a not-for-profit organization. If it were a business organization, I'm sure there would have been several clones that would have come up by now. The question is, how does one create a replicability in a non-profit organization? I'm not asking a question of you. I mean, it's a question which has troubled all kinds of people, and I don't think there have been easy answers to it. But I think that's a very important question, because L.V. Prasad is what it is because of one gentleman and his vision and the way he drove it over the last 30, 40 years. You really can't replicate and clone individuals like that. So that's a battle that one needs to keep fighting on. The other question is about poverty, technology, reaching the poverty and all. One needs to understand that the treatment one gets today is what was advanced technology 15 years back. Okay? And if it were not developed, then the poor today would not be getting that treatment. So it is not that, I mean, today everyone takes antibiotics. And antibiotics was at the forefront of technological development at some point of time. And so is a cataract surgery. Today, the poorest can get a cataract surgery done. But it was an advanced technology some years back. So to try to combine these issues of poverty, inability to afford, and technological research and development is an unfair comment to make. Technology always comes down and becomes usable to humanity.
Okay, so just to answer the question, medicine definitely is an art. It is something that is learned by spending amazing time with doyens in the field. And I truly believe today, because of many restrictions, both in terms of legal and also both in terms of skill set, the first thing that you are encountered with today is a barrage of investigations that people want to write out, just to make sure that they don't miss out on anything. But truly, I think it is being lost. And I think I don't have a complete answer to that, but it is more important for us to stay true to diagnosing someone by just applying what we've learned, rather than go down the path of unnecessary investigations. So I think it's not completely gone, but then I think it is something that is, we'll have to see how it evolves in the future. So I will distribute the percentage of the exclamation.
I suffered macular degeneration a few years back. I was treated by L.V. Prasad, and I'm in control. I want to know, how could you avoid macular degeneration and diabetic retinopathy? And diabetic retinopathy, how do you avoid? Can you avoid?
Diabetic retinopathy is a condition that affects your retina, which is the film of the camera, and almost 50 to 60% of the patients who have had diabetic mellitus for the past 15 to 20 years have some forms of retinopathy, sir. Yes. I just want to finish about diabetic retinopathy. So a regular eye check once a year for all diabetics is mandatory so that we don't miss out on any progression. For macular degeneration, unfortunately, which is the largest killer of vision in the United States today, which is the cause of irreversible visual loss, it is an age-related condition. And the unfortunate part about nervous tissue in our body is that it does not regenerate, for example, the retina. So cells that are actually damaged to a certain level cannot be regenerated. There is work that is going on in terms of stem cells introduction in the particular zone of damage. But of course, it is too early for us to actually take it on large scale to our patients to be offered as a treatment. There are other technologies that are coming into picture of the implantation of chips and electrodes in your eye and then connect to a receiver in your occipital lobe. It's called the Argus 2. It has been done in 2 patients in Europe. A highly expensive device. But still, these are all efforts in that direction to be able to give machine vision, at least to patients who have suffered irreversible visual loss. For macular degeneration, unfortunately, excepting for a few anti-VEGF treatments, there is not much we can offer in advanced diseases.
Yeah, good evening, doctor. I am Thomas. My brother was patient of LV Prasad 22 years ago. He was a difficult patient, but they succeeded. My question is, most of the diseases that we are facing is not because of atrophy or entropy, constant entropy, but because of our mistakes. If I say it doesn't mean, it will have a very less meaning, but if you say it will have, a new disease is coming up, some people, they switch off the light and they will play with the, smartphones or phones. And some people are losing their eyesight. So can you elaborate on that? Because it's an upcoming, young people are losing their eyesight because of this attitude.
Definitely. I'll definitely elaborate on that, because there is a new disease that has come into the picture because of the IT sector. It's a new disease. It's called as computer vision syndrome. It's an established disease. And when I find these patients and, now increasingly, I'll first describe adults and then children, how it's affecting them. So I find them come and say, doctor, this is how I feel. And I tell them, I've got nothing to offer you except these kind of advice for you to kind of take a break in front of your system and then use some drops. I think one of the things that we fail to understand is that something that we repeatedly do, which our body is not used to, is what actually leads to strain and then symptom that they experience. I always tell them that your eyes were never built for your computer. They were built for all distances. In evolution, our eyes developed because we could see from near, intermediate to far. And the moment you sit in front of a device, which could be near or intermediate for prolonged periods of time, just as you have fatigue in your muscle when you start walking, the eye also suffers from fatigue. But another disturbing trend that we are actually seeing right now, which studies have also proved, is that too much of near work in children is actually causing progression of their refractive errors. Too much of time on smartphones, tablets, is actually causing an increased spike of myopia that we are seeing. So it's hard to cut that, but I think it's just a side effect of development that has occurred right now. So I think
Dr. Amraksha. And I just wanted to ask you, since you are also taking a lot of open source, help on various issues. Do you share your insights or, your learnings over the what you have done? And maybe, that may help in, what should I say, replicating your solutions.
Yes, completely agree on that point. As I just said, not everything can be not-for-profit, not everything can be open source, right? So a part of what we do definitely is back for the community. But yes, the idea is to help scale this in a model that can sustain itself financially, right? Because most of these innovations that we are building, some of them that need scale, hopefully have the potential to go and be commercialized and then actually fund themselves so that they can reach many more people. So that is definitely on the cards. The second thing is another thought process that I'll share with you. So after this solution was built, the EMR solution was built, one of the ideas that we do have is to enable to, say, commercialize it, but then you make it open source for regions that can't afford it. So that is a very, very strong ethic that we also do have, is to go back and give it to individuals who might require it at probably no cost at all, keeping the ethic in mind. But then we are definitely mindful that not everything can be funded forever. And we are also exploring models which might help us take these ideas out there. So it's there.
Thank you, Doctor. I join everybody here in congratulating you for a very clear presentation. And in the many questions and comments that came round, many of what questions that I had in mind have already been asked. So I'll just limit myself to one or two questions or observations to which you might like to respond. One, of course, is the high cost of technology and also widening, in a sense, the divide between those who are digitally challenged and those who are digitally capable. That's one aspect of it. And in a sense, driving users out of the fold. Also, some of the negative points, like, for example, this gentleman in front just mentioned children losing their eyesight, smartphones, etc., which you talked about. You mentioned augmented reality, and in that context, what's in the news now, Pokemon Go. Of course, in the context of what you were saying, you were highlighting the plus points of augmented reality, but Pokemon Go has many more negative aspects, as we are all seeing. I don't play Pokemon Go, so probably I'm saved, I don't know. The other question I had was taking off from what Vikram said about, it's not just the physician. I was struck by the example you gave of the village to which you went, and where the villager produced a 5-year-old document of his wife. I didn't hear you say that you actually examined the wife and examined as a doctor her present condition. What is a 5-year-old document really going to do to somebody right now?
Right. I'll clarify both the points. First, I'll go for the document, and then I'll answer your first question. His particular query was about the incident that happened then and not now. And she was in the field, just to clarify. Right. And the first thing that you did mention is about the divide that is happening. I'll give you the classic example of the intraocular lens of Arvind Eye Care System. Arvind Eye Care System in Madurai, when Dr. V said, why should we pay $120 for an intraocular lens? Why can't we make it in India? Is when the birth of Aurolab, which is a fantastic beacon in ophthalmology in terms of subsidizing the delivery of care with technology. And today IOLs are as low as 60 rupees. And you're able to actually have these IOLs exported out for people to actually use. Social entrepreneurship as well, in the way they employ so many women at Aurolab and the way they're creating so many livelihoods around that particular initiative. Very, very inspiring. So, just as Harold Ridley found that a tent piece lodged in pilot's eyes was not creating any kind of reaction is when he went and built the first intraocular lens. Dr. V has brought that even available to the masses who need it. So, I think there are amazing success stories. There have been failures. But I think what we need to consider is that you all have a chance to have a go at it. So I think that is the point I'm trying to make. I think everyone should have a chance to go at it because you never know from where who is going to really make the difference in the world. With regards to Pokemon Go, the only point I wanted to make is that another aspect of fitness came out. It's a bad game. There are people walking into buses. There are people walking across ditches and off the bridges, but trying to find their Pokemon. But it's probably not the right way to exercise. But there was a report that somebody dogged 29 miles on the app by walk. And they said that this guy probably was on a fitness roll. So, but anyways, the point I just was alluding to is that what's something you think, I'll make this point, I'll just take some time on this. When the MIT media team was there in July with us, one of the things that we were talking about is what is the iodine of eye care? You might ask me, what is the iodine of eye care? Who would have thought iodized salt will take care of iodine deficiency? Salt is something that you take, and you have iodized salt. You've just piggybacked on something that is necessary for you, but you've also been to take care of another major problem, which is iodine deficiency. So when we are thinking of what is the iodine of eye care, what is the iodine of eye care, right? And we all know that we were really thinking very radical, how can we take something that we can piggyback on them and then help people get care. So recently we have embarked on integrating Aadhaar into the entire LVPI network. The whole Aadhaar card system in terms of identification of patients and everything. We are integrating that into our network today so that the patient, anywhere he can go with a single Aadhaar ID, he should be able to access his records and for us to see. Then we also, while talking to the Aadhaar team in Hyderabad here, they mentioned that they have an iris scan and a fingerprint. Now, when they said iris scan, we said, okay, here is somebody who's coming in and he's putting his eye into something for him to be recognized. Can't that be a tool for us to pick up something? Can't we piggyback on those kind of things that are anyways done? He has to come to do it to take his ration home. Something that is very crucial for him to do. But what we're trying to do is that can we now look at models that have been established, that are using technology, and can we add something to it so that at least we are able to pick up? Because our fight is against avoidable blindness. Our simple fight is against avoidable blindness. So by any means, if you're able to get there, I think it will be worth the effort. So, pardon? Oh yeah, it's a fingerprint and iris is what is used. Did they share it with you? Oh no. They didn't share. No, this was an idea. So that's what I'm saying. I just wanted to know whether they have No, they have not. Aadhaar has not shared any information with us. Okay. What I'm saying is that this is one of the modality of recognizing an individual. But just the thought that why can't we piggyback on that and design a device that might help? Yeah.
Kudos to your work. What I wanted to know is you have these primary centers and the secondary centers. Now, what are the budgets to it as your experience in LVPI? And what is the capability building model? And how much does it serve? How many people does it serve? What are the stats to it, or what are the metrics to it?
Yes. If you look at the vision center is the primary level care. And if you look at the secondary center, that is the next level of care. The model in terms of financial model that is built is that the secondary center serves both paying and non-paying patients. So the money that is generated from the paying patients goes back to us trying to support the non-paying patients. There is also a sale of a very low cost subsidized spectacles to actually keep the center reach their cost benefit recovery. When you come down to the vision center, every person seen at a vision center across the 130 centers every day is free of cost. Now you may ask, how does it happen? There are multiple hybrid models that help us do that. There are organizations who help fund the maintenance of 30, 25 centers to pay for the expenses of running the center, the capital expenses, the HR expenses. And also what we do is that by the sale of the low-cost spectacles, which is very affordable to the patient, we look at making that center self-sufficient. But everybody who goes to the vision center is seen free of cost. With regards to how the population that is served under each center takes care of, say, 50,000 population. We take a center that is at least 50 kilometers away from a proper ophthalmology center. We go to a geography where there is a need. And the way we plan our next centers also is based on this logic, that we should be able to go to areas where there is actually a need, which is also not far away from our nearest secondary center for referring our particular patients. And also, if you ask what is the skill set of people at that level, we can tell you that the same quality of instrument that you will see in the Banjara Hills campus, the same slit lamp, a Carl's Eyes you will see in a vision center. There's absolutely no compromise in terms of the delivery of service with regards to the instrumentation. Including the skill set of the individuals, a vision technician is actually hired from the village, and he's brought to Hyderabad for a 1-year course where they actually train in the basics of identifying basic causes of avoidable blindness and also do a simple refraction. And they go back to sustain the center in their village. So they are local, they're given a livelihood, and they also help maintain the center. Yes, there is attrition, the people who've left, the people who've moved on, but still this is the model that has helped us establish vision technicians at these centers. At the secondary center, there is a trained ophthalmologist. There's a trained ophthalmologist who comes to do fellowships with us, right? So we have fellowships at the institute where we have ophthalmologists who have finished their post-graduation come and join us. And they are actually deployed on a year posting in all the 15 secondary centers that we have. So essentially, you have a trained ophthalmologist, you have a trained vision technician, and we are using technology now to actually, of course, teleophthalmology, telemedicine has been a long-drawn thing, but we also take pictures on our tablet, we send it to the nearest secondary center, we get information from that doctor, and at least the patient has some sort of a correct advice. Hey, send him to Tudukurti, it's okay for him to come back after a year. The other thing that we are experimenting today, from the secondary center to the tertiary center, which are the centers that are in the cities, is with Microsoft on HiVout. It's like a WhatsApp. We all use WhatsApp. We all significantly might use WhatsApp. It's a simple app that helps you communicate quickly. So what we're doing now is that an image from a secondary center is beamed to groups of specialists. Like an image can go to only retinal specialists. A diabetic retinopathy image can go to a diabetic retinopathy interest group, a corneal infection interest group, right? And all the specialists can quickly comment, because all it might take for you is to be able to give an advice, at least a sense of direction for someone who's confused. The third thing that we are doing right now is a remote drone slit lamp. We all know drones. We all control drones. We have beautiful footage because of drones today, right? But we have already built a drone slit lamp that can be controlled sitting in Hyderabad, anywhere in the network. We've established at 4 centers where a doctor sitting in Hyderabad can actually remotely control a machine to be able to gather information of the patient sitting remotely. So essentially, it's not just a 2D image that you're wanting to see, but a 3D image. And a picture is worth 1,000 words. All we need is a picture.
Hello. Good evening, Dr. Vipin. Wonderful, interesting, and informative. I just want to ask you a question, lighter vein, no offense. You've been spending all your time for the service of society, and don't you have time for yourself? When are you going to get rid of your glasses?
Good one. Well, there's already an answer in our circles for that, because when people come and ask about refractive surgery, right, they sit in front of you, and you tell them everything about the surgery, you tell them everything, and then he asks you or she asks you, why didn't you take it? Why are you telling me to take it? I mean it's you come in and you're interested to take it. So the standard classic answer that a very senior ophthalmologist in the US has already given, which we all use in our forums, is like, I want to take care of my eyes to be able to take care of your eyes. So in a way, it's a personal preference. No pun intended. It's a personal preference. I don't want to go under the blade. but essentially, yes. I know. I do understand. That's why I just kind of thought I'll.
Sir, good evening, sir.
Good evening.
Since you are a doctor, I want to ask you one question, sir.
Yes.
Sir, actually, if you are looking into other countries like Western countries or any developed countries, most of the doctors are using these electronic health records.
Okay.
But is that in that way these electronic health records are using in India? Is that like that?
Oh yes. No, there's a huge change that is happening in the country. Thank you.
Okay, one second.
Okay.
But when I read in internet or some other sources, I found that Indian doctors are not comfortable of using these electronic health records. But in my studies, I studied that if you are using these electronic health records, you can serve the patient very well. You can give better care to the patient. So what are all the difficulties you are facing when you are using this?
Absolutely. Thank you. I'll start with your first point. When you said Western countries, I'll give you what happened in the Western countries, right? So about 5 years ago, when I was at the AO in Chicago, Obama announced that if you don't get onto the electronic bandwagon, we're not going to reimburse you, right? And I could clearly see the fear of doctors in that convention as they ran to the industrial zone, just trying to find something to start implementing, right? So there's one way to do it. That's that way. In India, if you look at it, it's a very positive change, right? Today, if you see most of the hospitals, they are going the automated way. But there is a difference. The difference is whether you have clinical information that is digitized or if you just have administrative information that is digitized. Administrative information being digitized has been there forever. If I tell you today that the road that we have taken, which is not really well traveled so far, is basically taken the clinical information and digitized it. Because today, I'll give you one example. So today, Dr. Rao has a single click link which shows him entire LVP in one shot with 1 hour delay. He was able to see what is the diseases of people coming in, what are the treatments that are being delivered, and more importantly, what I'm really excited, this is just scratching the surface. This is barely scratching the surface, okay? What we're really excited about is that you see the vision with which patients are coming in, and you see that greater than 50% of them are going out with better vision. So that is impact. Impact of serving 20 million patients is one aspect. But then if you're able to actually improve the vision of patients who are coming in by greater than 50% every single day, that is a very gratifying experience, right? So I think the benefits are huge. I think it's begun. The government also is doing everything in its might to lay down some principles. It's still a big gray zone that we are still moving around, but I think it is something that we can't avoid moving forward. So we better get onto the bandwagon soon.